Okay. Well, welcome everyone to Transcend's Professional Development Core Didactic Training Series session on Research Study Design. We are especially fortunate to have Dr. Paul Carson leading today's presentation. Dr. Carson is an infectious disease specialist who has practiced in Minnesota and North Dakota for over 30 years. He previously held several roles at Sanford Health, including chair of the Department of Infectious Disease, Director of Clinical Research, and Chief Quality Officer. In 2013, he joined the faculty of North Dakota State University in the Department of Public Health, where he taught on the management of infectious diseases in the Master of Public Health graduate program, and founded and directed the Center for Immunization Research and Education. While at NDSU, he was the recipient of the Mary J. Berg Excellence in Teaching Award, the NDSU Faculty Lectureship Award, and the NDMA Physician Community and Professional Services Award. He recently retired from NDSU, but remains on faculty in the Department of Public Health as an emeritus professor, as well as a professor in the UND School of Medicine and Health Sciences, and currently works part-time as a clinical research faculty member at Sanford Health. With that, I will turn it over to Dr. Paul Carson.
All right, thank you, Kent. Good afternoon, everyone. Hopefully, the fact that we've got maybe 47, 48 people here means you found the correct link. We had to make a quick change as the initial email had an incorrect link. So hopefully the other folks aren't struggling to find us here. Today, what I want to talk about is some of the fundamentals of research study design, particularly focusing on what we call epidemiologic research tools, sometimes also referred to as observational type studies. Now, this Transcend series focuses on clinical and translational research, but I want to make the case that some of these tools that I'm going to talk about today do fit well into certain types of clinical and translational research. So I'll share my screen here and we'll get started. And Ken, if you can give me the thumbs up, that looks okay. All right, great. So my goals for us today is to articulate some of the differences between experimental research and observational research, with that focus on this observational research studies. And I want us to be able to come away knowing how to recognize and construct the different types of analytic studies versus descriptive studies, and be able to go over some of their associated strengths and weaknesses. I'll finish very briefly with how to use the STROBE criteria to construct and report observational research. And then the last point, and an important one for me today, is making the case for clinician-driven research. And if I kind of had a subtitle or an alternative title to this talk, it would be, hey, clinical colleagues, you too can do clinical research, really. And I'm going to use some of my own career early in my career as an example on this. And a lot of what I'm going to talk about today is going to be aimed at my clinical colleagues, although hopefully everyone, I know there's a variety of different people listening in, hopefully everyone can benefit from some of this, but I especially want to focus on my clinical colleagues. So when you look at human research study designs, you can kind of have these two broad categories: experimental research and observational research. So we've heard a lot in our earlier Transcend Didactic series, and we'll hear more on some of the experimental research designs. And these are things like randomized controlled trials, either randomized or non-randomized. But a lot of what's reported in clinical medicine is what we call observational research, which comes into other broad categories, analytical and descriptive. And we'll go more into details on both of those here in just a minute. So if we look at the different types of studies that fall under human research study designs, it's kind of a pyramid with the weaker studies at the bottom, and we get stronger and stronger as we move up. So at the top, we have clinical trials, which most of us are familiar with, and you may have at the very top of that meta-analyses of clinical trials, so pooling, very similar randomized controlled trials. But then when you get past that, or below that, if you will, we're looking at epidemiologic studies, either analytic epidemiology or descriptive epidemiology. And you see these other types of study designs that we're going to go into today: cohort studies, case control studies, cross-sectional studies, ecologic studies, and then case reports and case series. These are not created equal. So as you move up this hierarchy here, they get stronger, and stronger meaning that any inferences or associations are much more likely to be true or causal. And on the lower end of things, we have to question because there are things like bias and confounding that can make these other types of studies weaker. That does not mean they're of no value. They are still potentially of great value, but we have to recognize that as we go up higher on this hierarchy, we have better and better or stronger and stronger types of studies. And that, as I said, gives us higher evidence quality, and it allows us to approach causal inferences. Outside of that, if you will, is the benchwork type research. So in vitro studies, laboratory studies, animal associated research. That doesn't really fit on this hierarchy of human studies, but it's very important because a lot of research questions will be generated here, but we would be pretty unlikely to make policy decisions, treatment decisions, diagnostic decisions based on in vitro or animal research alone. So that eventually we hope the knowledge that we gain from the bench gets translated into these types of clinical studies to where we then may make policy and practice decisions. So why are randomized clinical trials so important? I'm not going to spend much time on these, but the reason randomized trials are so important is that the observed effect that you see in that trial is much more likely to be reflective of the true effect. You decrease the risk of confounding and bias, and that's why it's really the king of study designs. But they're hard to do. Clinical trials require a lot of resources, both money and a lot of person hours. And so, as much as we'd like all of our evidence to be based on randomized trials, sometimes it's not practical to do those, or we may not have the resources to do that for every question we have. So then we often are looking to observational research. And observational research can be very, very helpful, but we have to recognize that the effect that we see or the outcomes that we see or the results may be a combination of the true effect and various selection effects that can muddy the water. And so we have to often adjust for that or take account of that as best that we can. And then we can't always do randomized controlled trials. And there are a number of examples of this. If you want to have a real fun read, I encourage you to pull this article from the British Medical Journal by Smith and Pell. It's this sort of delicious satire that was written at the kind of peak of the evidence-based medicine craze. We really try and strive for our clinical decisions to be based on evidence-based medicine, which in the late 90s and when I was going through training in the late 90s and early 2000s, we wanted everything to be a randomized trial. And they have this sort of satirical article on parachute used to prevent death and major trauma related to gravitational challenge, systematic review of the randomized controlled trials, no randomized trials. And then they go on in their satirical way to conclude that there's no definitive data that parachute use is protective. The anecdotally observed benefit may simply be a healthy cohort effect. Individuals who use parachutes are likely to have less psychiatric morbidity, yada, yada, yada. They kind of go on to make fun here. And then they advocate at the end for those big evidence-based medicines proponents. They propose a randomized controlled trial of these proponents with a crossover at the end to parachute use versus non-parachute use. You get the idea. But there really are a number of things where the randomized trial isn't going to be able to help us. Questions of etiology and risk. Rare outcomes or long-term effects sometimes can be very difficult to do in a randomized trial. Ethically problematic randomization. A lot of our health services and policy research is not very amenable to randomized trials. Real-world effectiveness. So you may have, for example, in my world, the vaccine trial, which is called an efficacy trial under sort of ideal conditions. Well, how does that really look when you do it in the real world? And how does it play out? Does it look like it has similar safety and efficacy? And that's called effectiveness. So effectiveness trials are often amenable to, are much better done with observational research. Health behavior and utilization patterns and identifying prognostic factors. These are all often better or more able to be done with observational research study designs. Here's a few examples of what I would say are empirical claims that really aren't amenable to a randomized trial. Does the measles vaccine cause autism? Big question right now with our current climate in the United States around vaccines. No IRB is going to approve a trial where we randomize a bunch of children to get a measles vaccine and another large equal group to not get a measles vaccine. It would not be ethically sound to potentially expose a large group of children to potential measles. Does radon exposure cause pulmonary fibrosis and emphysema? Similarly, we can't randomize people to potentially harmful things, right? So when it comes to harms related type research, we have to rely on observational studies. Similarly, does electromagnetic radiation from devices such as microwaves or Wi-Fi routers or power lines harm human beings? Not going to really get a randomized trial there. And you can see other examples here. At the bottom here, what factors predict survival in breast cancer? That's going to be better handled with observational studies. And observational studies can fit in this translational research framework. We heard about this in the first didactic series, the research framework. T0 being basic science research, T1 translation to humans, so that's bench to bedside. Then translation to patients, that's our clinical trials. But T3 and T4 are things like translation to practice, like implementation in clinical care, or translation to population health, for example, public health policy and impact type studies. Observational research is very helpful there. Here are a few examples of some epidemiologic studies as translational research that had a huge impact on our understanding of health and disease. Hopefully, you've heard of these first two. They're very, very famous cohort studies. We'll talk more about these study designs in a minute. But the Framingham Heart Study, which was a long-term, longitudinal, prospective cohort study capturing most of the population in Framingham, Massachusetts. This is where we learned about all of our major cardiovascular risk factors like hypertension, cholesterol, smoking, diabetes, etc., and paved the way for our intervention type studies and leading to guidelines for screening and treatment. The Nurses' Health Study is a huge cohort study of women who are in the profession of nursing, looking at a plethora of behaviors, habits, sort of epidemiologically derived potential risk factors for both health and disease. And from there, we've learned a great deal about cancer risks, diet, benefits and risks, hormone use, etc. And this is an ongoing study. And now they're studying the children of these nurses. It's called the Growing Up Gut Study. I can't remember what the TS is, but it's so it's a very powerful. These are very, very powerful studies that are not randomized trials. A more humble type of study design, which we'll get to in a minute, is a case control study. But it was a case controlled study that really discovered the link between cervical cancer and HPV, or human papillomavirus infection. And this paved the way for us to target that viral infection with vaccines for prevention. Another type of harm study. So going back to our hierarchy here, we're going to focus on these now epidemiologic study designs. And, so these are the cohort studies, case control studies, cross-sectional, ecological, case series, case reports. So back to our broad categories, observational, analytical, and descriptive. We're going to first talk about descriptive type study designs. And again, I'm emphasizing these because these are ones that are very doable for busy clinicians. These are things that you can kind of do without a lot of expertise, without a lot of statistical know-how, without a lot of money that you can do from our clinical practice. So descriptive type studies can be done at the individual level or at the population level. So at the individual level, we have things like cases, the humble case report, or a handful of cases, case series, or cross-sectional studies. Sometimes cross-sectional are categorized under the analytic category. I don't really care where it's put. We'll talk about what that looks like, but it's sometimes described under descriptive, sometimes analytical. And we'll break that down a bit in a minute. And then at the population level, we have what are called correlational studies or ecological studies. Let's first talk about cases and case series. So the case or the case series can be very powerful. So a lot of people do this sort of naturally. Like I had this thing happen to me. I got a COVID vaccine, for example. This was my world during the pandemic. I had an aunt who got the COVID vaccine and she had a heart attack 4 weeks later. Powerful sort of anecdotal case. Is it causal? It's at the very bottom of our hierarchy of evidence, right? So there's a dark side to these. They can open up important investigation, or they can be very spurious associations. Here's a couple of really important ones that really paved the way of our understanding about human disease. This was a report in 1981 in Morbidity and Mortality Weekly of 5 young men who were all active homosexuals who were treated for biopsy-confirmed pneumocystis carinii pneumonia. This was the sort of canary in the coal mine, or the bell that got rung first, that led to saying, this is a very strange set of cases, not something we would typically see in otherwise healthy young men, with the only sort of demographic risk factor that they were active homosexuals. And so that led to the investigation of what's behind this, discovering that there was significant immunodeficiency, and later the discovery of human immunodeficiency virus infection. Dr. William McBride was a pediatrician who had observed a couple of babies who were born with this very tragic birth defect of phocomelia, these shortened limbs. And it was in the investigation of these children born with phocomelia and doing essentially what was the equivalent of a case control study, finding that the distinguishing characteristic of exposures was that the mothers had been exposed to thalidomide during their pregnancy, a drug that was being used very effectively to treat pregnancy-associated nausea or morning sickness. Tragically, though, led to these birth defects. So these were very important cases that led to major public health implications. But then you can see things like this. I was sent this sort of stuff, constantly during the pandemic. A notable senator who was posting regularly on social media. All these athletes are dropping dead on the field after receiving the COVID-19 vaccination. What's going on? Is the COVID-19 vaccine killing young, healthy athletes? Or a whole website dedicated to, COVIDvaccineinjuries.com, where you could submit what you think was a bad thing that happened after the COVID vaccine. Here, this, journalist, 42 years old, who died of a heart attack. Now, when you read some of these, it was 9 months after his COVID vaccine, but the underlying assumption was, well, 42-year-olds don't die of heart attacks. It must be the vaccine. Actually, quite a few 42-year-olds die of heart attacks every year when you look into it. But this is the sort of downside or dark side of the anecdotal case. I do point out, though, that our brains are really hardwired to make causal inferences, and these cases can anecdotally be very, very powerful. This is Jenny McCarthy. She was a kind of B-movie actress and a daytime talk show hostess, who was at one time involved romantically with the actor Jim Carrey. And this is her son Dylan, who sadly had developed some kind of severe developmental disorder, in probably somewhere in the spectrum of autism, although that's debated what he has. But she became convinced that a vaccine caused her son's problem. And she said, he seemed fine and developing okay. He was vaccinated. And then some months later, everything seemed to change. And her statement often has been along these lines. He was vaccinated and something changed. My son is my science. I don't care what all you scientists say with all your fancy studies. I saw something change here. And I ask my students often, like, is she wrong to try and think along these lines or question this? And I would say, no, she's not. It's a fair question. We've got a lot of really great data that's way higher on that hierarchy of evidence now that answers this question, but it's not improper for someone to try and ask questions from from associations they think they observe. So the problem with the humble sort of case or case series is that there's a big difference between from versus after. So, my son had something change after he was vaccinated. Was it from the vaccine or just serendipitously after the vaccine? This is the post hoc fallacy. So the post hoc fallacy, fully stated, is post hoc ergo propter hoc, after it, therefore because of it. Um, the kind of classic false example here, the rooster crows, the sun comes up, the rooster crows, the sun comes up, the rooster crows, the sun comes up. If the rooster doesn't crow, will the sun not come up? It's a strong association, but it's a correlation, not causation, right? And there's many, many things that will fit under this bill. A really great example, this was described in Paul Offit. He's a pediatric infectious disease doctor, developed the rotavirus vaccine, writes a lot on vaccine policy. And he wrote about a story of a colleague of his in his book, Deadly Choices, about the anti-vaccine movement, about a colleague of his at Duke University who stood in line with his 8-month-old son to get, I think it was an influenza vaccine at one of these drop-in clinics. And his colleague waited and waited and waited in line and decided, I can't do this today. I'm going to have to come back another time. Went home. Very, very tragically, his son, 8-month-old son, died of what was presumed to be sudden infant death syndrome that night. And he came to the realization that had he gone through that line and had his son gotten, this first influenza vaccine and then died as he was destined to do that night, it would have been very hard to shake the idea that it wasn't that it wasn't the vaccine that caused that death, but it would have been completely wrong, right? So another example I gave is on this is that on any given day in America, like lots of bad things happen to people. You'll see about 540 cases of new onset of seizures, about 2,200 heart attacks and strokes, about 2,500 blood clots or DVTs. And about 8,000 people will die every day in America. That's a new seizure every 160 seconds, a new heart attack or stroke every 39 seconds, a new blood clot every 35 seconds, and somebody dying every 11 seconds in America. So if you're trying to kind of look back about bad things, that may have led up to that, you got to take account, what's the sort of background noise of these bad things and many, many others happening every day. And I give the example of lots of people trying to blame, for example, the COVID vaccine on these things. We vaccinated close to 2/3 of our population within a handful of months. Lay that on top of 2,200 strokes and heart attacks every 39 seconds, a person dying every 11 seconds, et cetera, et cetera. Of course, you're going to have some just serendipitous person dying or getting a heart attack or getting a stroke or some other bad thing within a month or a week or a day or an hour of their COVID vaccine just by chance alone. So we need better study designs to pull out the signal from the noise. We need to kind of be able to account for that, background of problems that may be a better explanation for what we're seeing. So as we move up the hierarchy of evidence, we can look now at descriptive studies at the population level, what we call correlated trends or correlational studies, or sometimes what we call ecologic studies. So this is still under that descriptive category. And I'll give you a couple examples here. Here's a graph of per capita meat consumption plotted against colon cancer incidence in women by country. And you can see from this graph that the countries that have higher per capita meat consumption seem to have a higher incidence of colon cancer. So this looks like a nice correlation between these two variables. It's looking at sort of trended, typically more than one variable trended over time to see if they correlate. And you can apply a statistical method to say how tight or how good or how strong is that correlation, and likely to be a real correlation as opposed to spurious. Here's another example that kind of paved the way for looking more carefully at cigarette use and its risk of lung cancer. This was a study out of the UK looking at the per capita consumption of cigarettes in the early 1900s, and about a couple decade later, incidence of lung cancer in the wake of those rising rates of cigarette consumption. Very tight correlation. Kind of raised the question, are cigarettes causing lung cancer? But this is correlational type research. It's not, it's only kind of getting us part way up that hierarchy of evidence. I'll give you some examples of why we have to be careful of these correlation studies. So here I plotted the autism rate, which is going up. There's a number of explanations for this, but autism rates are going up in the United States, and as kind of correlated with the number of received vaccines in children over time. We've added more and more vaccines to the vaccine schedule, and it kind of has a loose correlation with rising rates of autism. I played around with a couple other databases on this. Here's autism plotted against children with access to a home computer. Little tighter correlation. Here's another one, autism rates versus US subscribers to cell phone service. Maybe even tighter yet. Do we think cell phones or do we think computers are causing autism? I mean, you could ask the question, but just because there's a correlation doesn't mean it's causal. Some other clever person plotted the same thing against organic food sales. There's a real tight correlation coefficient there. Do we think, organic food is causing autism? There's a statistician I like to follow. His name is Tyler Vigen. He's got a website on spurious correlation. He's got a lot of stuff on statistics. He plays around with different databases and posts all these kind of goofy, spurious correlations. This is US spending on science, space, and technology correlated with suicides by hanging, strangulation, and suffocation. I mean, really can't make any plausible connection of why that would be. Here's my favorite one. Number of people who drowned by falling into a pool seems to correlate relatively well with the number of films Nicolas Cage appeared in that year. So humorous, kind of spurious correlations, which get at that we can't always trust these correlational studies, and that's because they're prone to what's called the ecologic fallacy. So the ecologic fallacy is that I incorrectly assume that an association at the population level reflects an association at the individual level. So for example, in that first slide of increasing per capita meat consumption by country, correlating with increasing incidence of colon cancer, we're not really looking at who ate meat and who didn't eat meat, or who ate a lot of meat and who didn't eat a lot of meat. We're looking at just trends by country. And there may be other reasons in there that explain that correlation better than meat consumption, for example. You'd want to move up higher in that hierarchy of evidence to say with greater confidence that meat is a driving risk factor for colon cancer. So I don't know who Catherine McCauley is. I just found this quote that I wanted to use. And her quote is, "A good beginning is of great importance." And that's what I would call these descriptive studies. They're a good beginning. They start a question. They're not the answer. They should generate questions and hypotheses. So yeah, if you think for 2 seconds what's missing from these descriptive studies, you have your study group here. But what is or individual or a handful of individuals, but what does a case or a case series or an ecologic study lack? It lacks a control group. One of the fundamental principles of the scientific method in both the bench and preferably at the bedside is really having a control group to compare so that we can try and get rid of that background noise and find the true signal in the background of the noise. So that's what we're trying to pull out. So we got to think about better study designs when we really want to try and answer the question. So let's move into this category of analytical studies. We're not going to get into clinical trials. Most people are familiar with those, but sticking with our observational research studies, we've got a handful of types of study designs here. The case control study or cohort studies are the big ones, prospective and retrospective. There's also called cross-sectional studies, which sometimes are put in that descriptive, sometimes put in this analytical category. We'll get to those in a second. This is a little bit more of a fuller breakdown of these. So when you look at analytical studies where we're trying to get to some kind of a control group, we can start with the question, did the investigator assign the exposure? So if the investigator is manipulating the groups and the exposure, that's experimental studies. And that can be either random allocation or non-random allocation. That's our clinical trials, right? And we're kind of not talking about that today. We're focusing on observational research. So the investigator did not assign the exposure. They're looking in nature. They're looking at natural experiments, if you will, to try and make comparisons. And so if they didn't have a comparison group, that's our descriptive studies that we just talked about. But if they are trying to get a comparison group, that's an analytic study. And these are where the exposure is not assigned, and these are what we call these natural experiments. And then we can look at the direction of how we're looking at the data. And this really gets to the crux of these types of study designs. So sort of on the higher part of our hierarchy of evidence, we can do cohort studies. So cohort studies are looking at groups separated by their exposure. So they were exposed to cigarettes, or they were or an equivalent group of people not exposed to cigarettes. They were exposed to radon, or they were not exposed to radon, or maybe beneficial factors. They exercise regularly, they don't exercise regularly. And then you look out from that exposure at these two groups to see if they develop the outcome of interest, heart disease, lung cancer, etc. You can go the other direction, and this is case control studies. You can start with disease. So I'm looking at the diseased group versus the non-diseased group. And then I look backwards to say, how many of you diseased people exercise regularly? How many of you non-diseased people exercise regularly, or whatever exposure of interest we're looking at? But our groups start with disease, non-disease, or whatever, category of outcome that we're interested in, and looking backwards at exposures. And then cross-sectional studies are kind of looking at the two things at the same time. I'm interviewing everybody in this group right now. How often do you exercise, and have you ever had any heart problems? That would be taking a slice in time of both exposure and outcome at the same time. So kind of showing this again, cohort studies start with the exposed versus non-exposed group and look out in time at outcome. And then case control studies start with outcome, disease versus non-disease, or outcome versus non-outcome, and look backward at exposure. And cross-sectional are looking at both at the same time. Again, these types of studies, particularly retrospective cohort, which I'll get to in a minute, and case control studies are very amenable to clinicians kind of mining our electronic medical record or other registry databases and so on to try and make these types of associations. So cohort studies, again, we're starting with the population, people without disease, then we look at the exposed versus the non-exposed, and then we get the numbers of disease versus no disease in the exposed, number of disease versus no disease in the non-exposed. And then we can get relative risks from that, or rates of the disease in these two different populations. That can start prospectively. Here at the bottom, the study starts. You look and see if the people get the exposure, non-exposure, and then look for disease occurrence later in time. Or you can even start it after the exposure, but before the disease. And so they've been exposed or not exposed sometime in the past, and then you're looking ahead to see if they develop the outcome. Retrospective studies, both have already happened. So your study starts here, and you're looking back in time at exposed versus non-exposed, and then looking to see, like in the electronic medical record or some other database, who did and did not develop disease. Again, particularly this design is very amenable to, with not very much cost, to researchers and clinicians kind of diving into our EMRs and other databases. Here's a very famous cohort study looking at tobacco smoking and lung cancer in England and Wales in 1951, and they looked at the exposure of smoking versus non-smoking. So the bottom group here, non-smokers, and then people who were light to moderate smokers, and then people who were heavy smokers. And then they looked at the number of person years at risk. And then they looked at how many cases of lung cancer developed over time. And then they were able to calculate from that a rate of lung cancer per 1,000 person years. And so you can see the heavy smokers had 32 a relative risk, or I'm sorry, 2.27 rate versus 1.39 in the moderate smokers versus 0.57 in the light smokers versus 0.07 in the non-smokers. And so then you can do a relative risk of that, and you can see that the heavy smokers had a 32-fold greater risk of developing lung cancer compared to the non-smokers, and so on. So oftentimes relative risk is the main outcome, final kind of outcome you're looking at for comparison's sake to make your judgments on these things. And here's some other examples of famous cohort studies. I've mentioned the Framingham Heart Study and the Nurses Health Study. Ongoing ones, the NHANES study, MAX, Physicians Health Study, ALSPAC. These are big, ongoing prospective cohort studies that give us a lot of great information, very powerful studies at looking at associations. These are the kinds of studies done over time that are going to give us most of our information, for example, about who's at risk for later development of Alzheimer's disease, as an example. So the advantages of these cohort studies are that they can be done where randomization is not possible, particularly like with harm studies. They can establish a population-based incidence. They can help us calculate relative risk or risk ratios. They can examine rare exposures, for example, like asbestos exposure to lung cancer. I can take a whole bunch of lung cancer patients and look back and say, with a survey, have you had any of these types of exposures that might have, put you at risk of being exposed to asbestos? You can have a temporal relationship that can be inferred, but particularly with prospective study design. You can get a time to event analysis. Gee, we follow these cigarette smokers. How much time does it take them to develop their lung cancer? We can get some good information about that. I can get a magnitude of the risk factor. Heavy smoking seemed to be a lot more than light smoking. So there was a dose effect there. These tend to have lower problems with bias. It doesn't eliminate bias, but it tends to be lower, especially in the prospective study design. So selection and information biases tend to be less. And you can look often at multiple outcomes. For example, I can start with my exposure of smoking, but I might be interested in more than lung cancer. I might want to look at lung cancer, COPD, larynx cancer, and a number of other things as outcomes over time. And you can do that with these cohort studies. Disadvantages, the prospective studies are often very lengthy and they are expensive. They're not easy to do. That's less of a problem with retrospective cohort studies. They often may require very large sample sizes to get enough power to find differences and associations. They're not suitable for real rare diseases, not suitable for diseases with a long latency. If it takes you 50 years to develop the problem after an exposure, that might not be very amenable to a prospective cohort study. Unexpected environmental changes can influence the association. If some other thing if I'm doing a smoking study around Chernobyl and, Chernobyl happened and, that's going to throw off all of my cancer calculations, right? So environmental factors can influence that association. Non-response, people not, following up, people who move away, you lose them. So there's loss to follow-up biases. You can also have sampling and ascertainment and observer biases, which is beyond the scope of this discussion today, but bias is still a problem, potential problem here. So moving to case control, an even easier study design to do. You're starting with a population and you're trying to find in that population a sample of cases and comparing them hopefully to a well-matched set of controls. So diseased people, heart attack, stroke, cancer, whatever, and control group, people who look very similar to those cases but didn't get the disease. And then we look backwards to see how often or how many of you were exposed to whatever thing I'm concerned about. Exposed, not exposed in both groups. And I, again, try and get some kind of proportionality there. Here's another just graphic of this. Population with the outcome, my cases. Outcome, exposure, no exposure. Population without the outcome, exposure, no exposure. And then I derive some proportions there. The advantages of these case control studies are they are cheap, they're easy, and they're quick. So again, for busy clinicians who kind of want to put their toe in the water of doing some kinds of studies, this is a very useful study design. You can look at multiple exposures. rare diseases and diseases with long latency can be studied. I can try and grab every mesothelioma case in, the EMR, and match those up to controls and then look back, with surveys or other things to find out about asbestos exposure. Mesothelioma, a very, very rare cancer, but you can do these kinds of studies on that sort of thing with a case control design. And it's similar to the cohort studies. It's suitable when randomization is unethical. Disadvantages, trying to get your cases and controls, selecting them well, matching them well can be difficult. It is subject to bias, selection bias, recall bias. How well do the people recall the exposure you're asking them about? Oh, I forgot that I worked in shipyards, putting asbestos stuff in the ship, How well are they recalling, the exposure? How well do they recall how much they smoked if you're asking about it from the past? Direct incidence estimation is not possible. We can't get a true incidence like we can with clinical trials and cohort studies. Temporal relationship is not always clear. Multiple outcomes can't be studied. If the incidence of exposure is high, it's difficult to show the difference between the cases and controls. It's not easy to estimate the attributable fraction, and reverse causation can be a problem. Which is causing which. We can't always say that. All right. This is a slightly different pyramid of the hierarchy because it includes one other study design I want to mention, and that's this middle one, quasi-experimental studies. So quasi-experimental studies are another one that I think are really potentially useful for clinicians, not real hard to do. And what are quasi-experimental studies? So this is a definition here on the side. Quasi-experimental study design is a research method used to estimate causal relationships without random assignment. So this is often our non-randomized type of trials or observations. So unlike true experiments, participants are not randomly assigned to conditions, but the researcher still might be manipulating an independent variable. I'll give you an example of this in a minute here. This design is often used when random assignments kind of impractical. I'd say it's often also used when people just don't want to go through the bother of trying to randomize stuff because it's easier to do. But you can still get good information from these. And the kind of two examples of these study designs are something called time series analysis. Measurements are taken multiple times before and after a treatment or an intervention or a policy change. You got a period of time before whatever thing happened that you're interested to see what the effect was compared to after that period of time. Or pre-test, post-test design. Participants are measured before and after receiving a treatment to assess changes. So these types of studies often look like this. You've got a control group, that's got some kind of outcome that's maybe getting worse over time. You do some kind of treatment intervention or policy intervention, and you see, is there a change in that trajectory in your intervention group, right? Common pitfalls of these observational research designs and analyses. I've got them listed here, but there's a number of them. You don't need to know all these in depth. You need to get a good statistician or one of the research, faculty or staff that are available at Stanford, that are available at UND, that are available at NDSU. There's people out there to help attenuate these different types of biases and confounding that we need to do our best to account for to make sure we're getting closer and closer to a real relationship and not something that's spurious. Before I kind of talk about some of my own real world examples, I'll finish with what's called the STROBE criteria. STROBE is a group of experts on observational research that came together to put out guidelines and documents on strengthening the reporting of observational studies in epidemiology. That's what STROBE stands for. So here's their website at the bottom. If you're thinking about doing any of these kinds of studies, I encourage you to start here. It's a great checklist on how to think about, let me put this together the best I can. And if I follow this checklist, a lot of the publications that publish this type of research want to see that you did the STROBE criteria, STROBE checklist. And it just kind of gets your ducks lined up in a row well to do this right from the start. All right. back to my plug to my clinical colleagues. Clinical colleagues, you too can do clinical research. I want to give you a few kind of real world examples of this. So I'll make the statement that I think clinicians are uniquely situated to do clinical research. Why? First, you have expertise in your field. You've trained in medical school, and then more particularly in residency. Some of you in fellowships to have a great deal of knowledge in your field. And if you're a practicing clinician, you're the closest person to the day-to-day clinical problems and issues that really affect your practice. And then most of us, by nature, are curious. Most of us are intellectually curious. And that is the greatest asset you can bring to doing clinical research. You don't have to know everything about statistics or research design or bias. Lots of people can help you with that. The first big hurdle is just asking good questions. I encourage you to go back and watch Dr. Williamson's presentation. Was yours the last one, Mark? Yeah. So it's recorded on the Transcend website. He gives a very nice presentation about different ways to generate hypotheses. I'm going to give you a few others to think about. But bringing your curiosity is really one of the biggest assets you can bring to clinical research, and particularly because of that day-to-day experience in clinical problems and issues that affect your practice. So where might your research ideas come from? Go back and watch Dr. Williamson's talk. He gave a number of really good examples on how to generate ideas. For the clinician, I would suggest a couple different sources also. So I think, many of us experience empiric claims, health claims getting thrown at us every day. A lot of them that we might suspect are garbage, or we don't really know, but like, has there been research done to answer that question? You can have Dr. Oz promoting his green coffee bean max is going to burn your fat away and make you skinny in a few months. Is that true? How's that been studied? What kind of he's got 3 or 4 anecdotal people touting it or whatever. Is there anything better? Can I do a kind of better study to design to answer that question? The anecdotal cases from COVIDvaccineinjuries.com, or the posting in the newspaper about people worried about, high power lines are going to give them brain cancer or whatever. We get these empiric claims thrown, and you can go the next step and say, well, what kind of research has been done on them? Something Dr. Williamson said in his last talk is read a lot of papers. I know that sounds a little, tough because you're busy, but when you are curious, just doing that first step of starting to, what's known about this out there? What's been published? Is there anything, is the only stuff published on that really low end of the evidence hierarchy? Can I do the next step up to make it a little better to answer the question? Or can I validate it even with a case series of my own doing, move up that hierarchy? I'd say more importantly is your own ideas. And I got my corny picture here of me, with my quizzical thinking about what I'm curious about. And I'll give you a few examples of things that came up in my clinical practice. I was a busy clinician for most of the first 2 decades of my career. And different questions came up in my practice. North Dakota was hit very hard by West Nile virus. I think from about 2003 to 2007, we were kind of, the upper Midwest was the epicenter of the West Nile virus epidemic in the United States. And we probably, I think, still to this day have more cumulative incidents than most other states. We were seeing a lot. And I was seeing a lot of patients who had gotten West Nile, even the milder forms. So there's 2 sort of flavors of West Nile virus. You can get really sick with encephalitis and meningitis, or you can get what's called West Nile fever, which is kind of a flu-like illness. And I was seeing a lot of patients back 3 months, 6 months, 8 months, a year later who had just had West Nile fever, who just still weren't firing on all 4 cylinders. They said they had brain fog, they were tired, they were fatigued. And so I really wondered, well, can this milder form, which everybody that was writing about it, reading the papers now, I dug into the literature, everybody was saying this is a benign illness that's just like the flu and goes away, after a week to 10 days. I wasn't so sure. So I found that there really wasn't much out there on this question. And I thought, I wonder if we can look into this. And I got a very small grant from what was then Merit Care Foundation to get a research coordinator to help me gather data. I bribed one of my neuropsychiatric colleagues with Thai food lunches to come in and help me look into this. And we brought a whole bunch of, we solicited people who had been reported as having West Nile virus infection the year prior and brought them in to get a neurologic exam and a battery of neuropsych tests. It did not cost me much money at all. And I bribed a very nice statistician with just Thai food again. He was very kind to me. You're not going to get this every time. You're not going to get a statistician giving you free help. He did. It was wonderful, and I learned so much from him. So we did a study on long-term effects of West Nile virus. Another one that was sort of bugging me regularly on rounds. So I would go on rounds with my students and residents, and a good percentage of our patients were in contact precautions for methicillin-resistant staph infection or colonization that they might have had years before. So they get this flag on their chart that they've had MRSA, and forevermore, whenever they come into the hospital or the clinic or healthcare facility, you got to put on a yellow gown and you got to put on gloves. And we were filling up landfills with these yellow gowns and gloves for these people with this flag for past MRSA. And I wondered, like, gee, are we doing anything here? Are we really preventing, transmission of MRSA in the hospital by, having all these people in contact precautions? And we knew that people that go into contact precautions actually suffer less care. The nurses visit them less often. The residents and doctors visit them less often. They're more likely to have negative, emotions. They're more likely to fall, etc. So I thought, well, maybe we can look into this. Maybe we can bring a whole bunch of these people with this flag on their chart back, swab their nose and see if they're colonized. Maybe do it even a couple times over time to make sure we're not missing somebody, and see, how many of these people are still colonized 6 months, 8 months, a year, 5 years, 10 years after their past flag for MRSA. Here's another one that came up regularly in the practice. So I had some colleagues that wanted to try and improve the way our clinicians gave antibiotics for sinusitis. We knew from lots and lots of studies, both internal and published studies, that antibiotics are grossly overprescribed for sinusitis. There's only a handful of reasons to give antibiotics with a sinusitis diagnosis. And so they put into the EMR a pop-up that said, hey, looks like you're giving an antibiotic for sinusitis. The guidelines say you should only give it if they've had symptoms more than 10 days or severe pain or they've had a high fever, etc. Do you still want to give the antibiotic? And then they could click through and say yes or no and so on. So I wondered, is this doing anything? Are we making anything better with this pop-up? Are we improving antibiotic use? That was a sort of before and after study that cost me no money at all. So what happened? I was able to do these studies. The West Nile one, it turned out to be a very nice study with my colleague that got published in Clinical Infectious Disease, was one of the first to look at long-term outcomes of West Nile, and then several other people were doing this, and that literature grew and grew and grew. We published on with a little. It's really great if you can get a catchy title in your, for your paper. I think there should be some study on how often papers get accepted if you got a clever title. So my colleague on this paper said, "Oh, let's do the bringing down the flag, kind of removing the flag of your MRSA from the chart." We were able to show the vast majority of these people didn't have MRSA anymore. I mean, we were putting them in isolation for no good reason. And as it turns out, the best practice alert, we published this one, didn't do squat. I mean, not one bit of change in antibiotic prescribing. So all we were doing was annoying physicians, slowing them down, making them frustrated. Like this was a very poor quality improvement measure. What were these study designs? This was a retrospective cohort study. This was a cross-sectional study of a retrospective cohort. And this was a quasi-experimental study of before and after. Relatively easy study designs. These two were funded with very small grants. This one didn't cost me anything, just a little bit of my time. And I always leverage, as many colleagues as I can to help me. Many hands make small work. I had a number of my pharmacist colleagues helping on this. All right, one more here. This was in, I think, 2006 or 2007. We were seeing a fair amount of West Nile, and I had heard a rumor that the blood bank was rejecting up to 5% of all donors, this was in the summer of, I think it was 2007, that they were rejecting 5% of all donors because they were viremic. They had West Nile RNA in their blood at the time they came in, presumably asymptomatic. You're not coming in when you're feeling really sick. They're coming in, presumably not feeling sick, donating blood, and 5% of them had West Nile virus RNA in their blood. That just struck me as like, gee, that seems like a lot. And I just thought, boy, shouldn't we be seeing a lot more severe cases? Because the literature had reported from relatively small, not very great study in New York that about 1 out of 100 people are going to get meningitis or encephalitis. I thought we should be flooded with these severe cases, and we had some, but we weren't seeing what should have been, thousands of cases of meningitis encephalitis. And I just thought it seems there must be a lot of asymptomatic infection. Well, this question in my mind led me to make a few calls. I called United Blood Services and I said, "Hey, I'm just Joe Schmo over here at I can't remember if we were Sanford yet at this time. I think we were. And I hear you've got a lot of West Nile and you're having to reject a lot of blood donors. Just wondering if I could get some serum from you guys on your donors at the end of the summer, going into the winter or fall or winter." And test them for antibodies to West Nile. See how many people have been infected with West Nile in the past. So you make antibodies usually in four weeks or so. And the manager of United Blood Services was a very nice lady who we've later became very good friends. But she said, I don't know that I can make that call or make that decision. That's going to have to go to our president of research, and he's in San Francisco. You're going to have to talk to Dr. Michael Bush. So they referred me up to him, and I was like, oh man, this is going to go nowhere. Dr. Bush is a big shot. He's got hundreds of publications, high-powered journals, lots of virology research, lots of stuff on, bloodborne pathogens. But she made the connection for me. I gave him a call, and he was very nice, very generous, very pleasant. And he said, I kind of like your idea, but I think we should involve someone else to think about whether we want to do this or not. I want to reach out to Dr. Lyle Peterson, the head of vector disease at the CDC. So I'm going to put us on a conference call, and you make your pitch. You pitch to us your research idea. I was not an experienced researcher. I was just Joe Schmo clinician with a little question. I was very intimidated by this, and they couldn't have been nicer, kinder, more generous people. I made my sort of pitch, and they both said, I think this is a good question. I like this idea. Let's get a huge sample of donors from North Dakota after the West Nile virus season in 2008, and we'll test them for antibodies to West Nile, and then I had the idea of let's correlate that with how many people were reported for severe disease, meningitis and encephalitis. Most of those do get reported. They said, "Yeah, we like this idea. Let's do it." And then I later kind of said, you guys don't need me. You have the blood, you have the test, you have the expertise. I have no money. And they couldn't have been kinder and more generous. They said, "This is your idea. You write up this study. You're going to take the lead on the paper. And yeah, we'll do all the testing. It cost me nothing." They did all of this. So we tested almost 7,000 blood donors in North Dakota. And then we correlated that with how many people, and we broke them down by age and sex, and then correlated that with how many people in those same age and sex strata had been reported over that period of time from 1999 to 2008. 99 is when West Nile was introduced in the United States. How many people in North Dakota had a report of neuroinvasive disease. And we were able to show, so this might be of interest to you. You can look at if you're male or female and your age and what was the likelihood as of 2008 that you were already infected with West Nile virus. I mean, if you look at young males, it was almost 13% of all young males had been infected with West Nile virus. And then we were able to kind of correlate that with how many reports of severe disease were in those age groups. And came up with these risk ratios. So it was a lot less than 1 out of 100 for most age groups, except for the very elderly. This was a cross-sectional and ecologic study. And then from that, we were able to do another study where we kind of calculated what we thought was the cumulative incidence of West Nile throughout the US. So it was a wonderful collaboration that I never would have dreamed might have happened, but I just made a phone call and asked a question. That was a modeling study. So I could go on here. This was another study on, and I know we're at 1 o'clock, a quasi-experimental study on antibiotic use in primary care providers where we gave them a report card, like how often are you given an antibiotic when you really shouldn't for something like what is essentially viral bronchitis? And we gave region A the report card, and we didn't give region B. This was Sanford Health, and there was a big drop in how often they gave an antibiotic after they saw that, you're like a C or a D student. You're not the A student you think you are. They weren't happy about getting this report card, but it changed behavior. And we even got a call from this quality monitoring group in Minnesota saying, "What are you doing there at Sanford? Like you're having a huge drop in this inappropriate prescribing for this quality measure we track." And it was really nice to see that. That was a quasi-experimental study design. So my last pitch again, how about, thinking about with some of these easier to do, less expensive, oftentimes you don't need any money to do these, might you consider giving that a try? And I went over, I'm willing to stay on late for anybody that wants to, for any questions. I'll stop sharing there. And thank you for your time. Sorry I went over by a couple minutes here.
Okay. Well, we have a question that came up in the Q&A already about the blood study. So wouldn't you need donor permission to be using their blood sample before doing testing that they did not consent to? They're wondering about ethical considerations.
Yeah, so you certainly have to run all of this. All this has to go through your IRB. And in general, when you are doing studies on blood or laboratory specimens where you anonymize the data, you're not collecting it in any way that has identifier information. And there's a lot of steps to make sure you do that right. You, in general, don't need consent. And I don't remember what there may be some. In fact, I do think when you consent to give blood, I actually think United Blood Services and the other blood donor services have a little caveat in there that we may use your blood for these other purposes and studying different things and so on. So I think you get that anyway. They're very rigorous about their ethical research protocols, and so I think both those factors they do cover that. But even if they didn't, IRB typically allows when you anonymize that data that you don't need consent. You do need IRB approval, but you don't need consent. Other questions? Yeah. So who said this? Dr. Schwartz made the note, and very important. To my comment about bribing statisticians with Thai food or otherwise, he emphasizes, and it's a great segue to another point to make. Dr. Schwartz, who's the head of the Transcend grant that this didactic series is under, emphasized that Transcend has statisticians who are funded to provide statistical help. So there's lots of help out there. You just ask around. Transcend, UND, NDSU, Sanford. They're oftentimes they are funded from other means, or you can contract sometimes with small grants and so on. But that should not be a barrier. And these statistical colleagues can really help you buff up the study design and the comparison groups to get a better analysis out of that. So thank you for that, Dr. Schwartz. And I'd also mention, and Kent, I don't know if you put this in the chat, but we have the new request for proposals out. So Transcend has available funding for small grants. Where we've got funding for about 4 to 5 small pilot project grants. And we're now accepting proposals for that for 2026. So think about your ideas. Put a initial proposal together. Hopefully in the chat is the website for, yeah, there it is. It's in the website. Dr. Williamson just put it in. Go take a look. You'd be amazed at how much you can do with these types of study designs that I just gave you with $5,000 or $8,000 or $10,000. I mean, most of those things several of those things I did were done with less than $10,000. One of them was $15,000, but not a lot of money can get you down the road on with these study designs. Is there any other questions, Kent or Mark?
I'm not seeing any.
Okay, great. Well, we are over the hour, and I appreciate you guys sticking with me this long, and get out there and test a couple ideas and read some papers and see if you got an idea you might want to throw out for a proposal. Thank you, everyone.
Thank you, Dr. Carson.